We are going to make this informal and engaging and fun, I hope. So we're here to talk about trauma-informed care, clinical interventions. We're trying to also be welcoming, but sometimes you have to have some attention here, right? So here we go. First of all, I'm Sheri Dawson from Nebraska, and it's my pleasure this afternoon to have two colleagues next to me that are so knowledgeable about trauma-informed care. Joan, Gillece, who I just love, and she and her team members have been in Nebraska, and we've been able to accomplish great things because of her ideas. And so it's my pleasure to be on this panel. And with Mark, I have heard about Mark for a long time through Tracy and through a lot of the readings and some of his early innovations really with the IDDT in integrated care. And so I'm very excited to hear what you also have to say. I'm just going to couch this real quickly as a nurse that has some tenure, let's just put it that way, 36 years. And I think about when I go talk to nursing students that I tell them that I was a nurse before they had universal precautions in physical health care. So 1987-ish, they finally have the concept of universal precautions where it is the expectation that folks had issues, health issues that we needed to protect ourselves physically as we were drawing blood and caring for the patient, and it wasn't the exception anymore. And you think about trauma over that time, and 20 years later, the opportunity that we have to ensure that we're serving people that we know have experienced trauma and how we move that forward. I also go back real easily to that same time when universal precautions came out, and I was working at Dallas Methodist Hospital on a neurology floor. And there were individuals that had experienced a variety of trauma, car accidents, motorcycle accidents, stroke, shootings, those kinds of things. And I think about what we did not offer people at that time because of where the science of trauma was. We knew at that time that those traumas were life-changing, but I don't think we fully understood that they were really brain-changing and the opportunities to be able to move and serve people differently. So I'm really, really excited to turn over the mic to these two experts and talk about trauma-informed and clinical interventions.
Great. Thank you. Thank you, everybody. So is everybody still awake? Got a little caffeine going. Okay, I told Mark, I said, you're going to have to sing or dance or do something because it's the end of the day. And so we're going to try to really keep this as conversational as we can. And so if you have questions or comments, you don't have to wait till the end. Just raise your hand and we'll try to keep this much more of a dialogue. So what? Oh gosh, I'm going to drive you crazy. I'm going to drive Megan crazy for a change because I've just broken the rules, which I never do. Who's laughing? So I have had really the honor of overseeing the activities of SAMHSA-funded National Center for Trauma-Informed Care for the last 12 years, where we've been able to provide technical assistance and support to publicly funded systems across the country. I think we've probably been in some way or another to every state that's represented here. So whether it's working in substance use, mental health, juvenile justice, adult justice, persons living with HIV, homelessness, what we're really addressing is the impact of trauma across the lives of these folks in multiple systems. Unfortunately, SAMHSA is not funding the Technical Assistance Center next year. They're moving to regional centers, so all of our national technical assistance centers are going to be really, the funding will go into regional centers that you'll be able to apply for technical assistance. So think about trauma when you can apply to your regional. We're not disappearing, but we're not going to have the opportunities that we did and are so grateful for actually to SAMHSA. I've learned so much by doing this work for SAMHSA because what I'm most proud of the work that we've done is we're on the ground. I mean, we didn't come up with these ideas in a conference room or in an academic setting, with nothing's wrong with that. But we did it through being in the state hospitals, in the programs, in the homeless facilities, and really learning from many of the folks that we've provided technical assistance to on the innovative approaches they've had to be able to make a difference. You know, everybody talks about trauma-informed care. It's such the buzzword. Trauma-informed. When you're writing a proposal, you have to be trauma-informed. When we get to saying, okay, now that you understand trauma, we know the prevalence, everybody gets that, what do you do about it? And that's what stumps people, because it's such a shift in the way that we do business. And I'll tell you a few examples of incredible creativity we've seen when those with the most contact with individuals served, your officers, your direct care staff, are provided the education, not the training, but the education on understanding the meaning behind behavior, that they come up with incredible solutions. So when you're really looking at elevating that workforce by understanding that you don't have to be a therapist to be therapeutic, some of the best therapists I know are not therapists, right? They are those people that are driving the buses or working the units or in the cafeteria lines. That's where things really happen. There's nothing to say that the clinical interventions clearly are critical, but that takes a couple hours a day maybe. What happens the rest of the time? So how do we elevate the role of those folks and provide them the respect that they need? So with the funding from SAMHSA that will be moved into the regional offices, we've tried to be as creative as we can and have applied for as much additional funding as we can. We have a grant from the Office of Victims of Crime to be able to do a project to increase accessibility to vulnerable, underserved populations who are victims of crime. So we're doing a project in 3 states with that. We have a contract with Maryland Department of Juvenile Services to do their entire system, both an intervention for the youth as well as working with the staff. We've been working with Georgia to do their forensic system and to do some of their other state hospitals. We have a contract with California to do all of the state hospitals and bringing in the trauma message, and we're getting ready to start doing DC Department of Corrections and New York Department of Corrections as well. So although we don't have the SAMHSA funding, we're not stopping. We really believe that that NASHPIT has a great role to play and a great reputation that we can branch out into other programs. We also are, I want you to know that we're available to do technical assistance to the state within your own training budgets as well. It's really what I love to do. I come from the state system. I started volunteering in the state hospitals when I was 14 years old at Spring Grove, Barbara. We were talking about Spring Grove. And I never left. So that's been like 10 years that I've been doing this. It's been a wild ride. But so I come to this from learning through doing. And I think everyone that's on our team comes to this from learning through doing. So some of the things that, like I said, I think the uniqueness of what we've been able to do through the National Center for Trauma-Informed Care and our new SAMHSA Center our new NASHPIT Center for Innovation in Trauma-Informed Approaches, I think we've really been able to work again on the ground to help people figure out how to implement. And some things we've learned, Savannah Hospital in Georgia, forensic program, doing incredible, incredible things. We did a focus group with women on the forensic unit, and one of the women said, you know what, this is a patient, this is our home, and I think we should be able to do the orientation for folks that come into our home. I'm like, right on, this is terrific. So they have a welcoming committee, and it isn't just a welcoming committee, these are what we expect if you're gonna be a member of our household, right? Very different than the staff setting up these rules that this levels that playing ground. And this is what we expect, this is what we do. They're doing incredible things just through empowering also the women. Under the direction of a new forensic psychologist that came in, Dr. Stephen Barron, we wanted to work with all the direct care staff. We said they're the ones who need the opportunity to learn. It can't just be the clinicians that go to training and they're on the units. So of course we heard the whole thing, well, who's going to watch the units while they're in training? And we said, how about you guys? How about the clinical staff, right? And he said, you know what, that's a great idea. This is not rocket science, right? And I'm not talking any additional money. So he watched the units while the staff came to the training. He told me, he said, this is the best day I've had since I've worked here. It was really incredible. I got to work with the patients. I got to learn what was going on. So then we took it a step further. We said, okay, he did a one-on-one with that a direct care staff normally did. We said, okay, what if the clinical staff had to do the first hour of a one-on-one? That's how to reduce one-on-ones, by the way. But why, with the person with the highest level acuity, shouldn't they get the opportunity to be able to start that one-on-one with the person who has the most amount of experience, right? Make sense? So they started trying to do that, and it's really been an incredible shift. It's really made the direct care staff feel valued. It's elevated them, really incredible stuff. Ancora State Hospital, New Jersey, one of my favorites. Done incredible work, again, with the direct care staff. Direct care staff, we met with a group of them, mostly African American, large men, and their job was to respond to codes. So we had very, very frank discussions. They said, that's not what we want to do. We don't want to do that, then have to try to jump into a therapeutic relationship with the person. We really want to be helpers. They switched it all up. They are now the trauma champions. They name themselves trauma champions. They've learned to do all the trauma training. They're training others. They're responding in prevention. If someone's starting to feel dysregulated, those trauma champions are called to take it down a notch, not to restrain, right? Really elevating them. They're incredible. Under the leadership of Chris Morrison, who's the superintendent there, we've taken on some really difficult elephant in the room issues, such as racial inequity. Most of the direct care staff are persons of color, and oftentimes the administrative and a lot of the clinical staff are white. And even though people try to be respectful of one another, it's still an elephant in the room. And we've taken it on in a really respectful, thoughtful way that we decided through all of these things. The direct care staff are now in every executive committee, not the supervisor, a representative for the staff. They are on every treatment team, whereas before we were told those direct care staff can't be on the treatment team because who's going to watch the units if they're on the treatment? Well, you know what? They know the patients best. They're on the treatment team. And the best is they now train with us. We have a group of 6 of these guys who before were just taking people down when they didn't want to, who are now the trauma champions. We've sent one to Savannah to the hospital. He trained the direct care staff. These are the things that I've learned to do. One is going out to California. One of the guys is getting ready to go out to Napa to work at Napa State Hospital. We've sent another one to a facility in Atlanta. So really being able to move it forward, it's changed the whole dynamic of that facility. So trauma-informed care is really, it's understanding the meaning behind behavior, right? But it's really just good practice. It's really just treating everyone with dignity and respect. And it's really about that simple. So when we go in and work in programs, we start at intake. What does intake look like? How can we switch it up to maybe the first thing you're asked is, tell us what you do that you're really proud of. It just changes the dynamic. Then you can get to all the other stuff, right? But let's start with not looking at your deficits. Everyone knows their deficits. They've been through this enough. Start with the strength. How can treatment plans be then? Take that information, and that's what you work with in your treatment plan. You want to get that person back to what they did at one time in their life they thought was right. Right? So you're really elevating, empowering. When people get it, Hawaii Women's Prison, under the leadership of Mark Patterson, an incredible warden there, when he understood trauma, he said, you know what? When women, he ran the women's prison, when women come in, they have lost their families, their children, they're totally devastated. They're all trauma survivors. They've all had trauma. He said, when they first walk in now, this is how they're going to be greeted. This is a place of healing and forgiveness. So you can imagine what happened to violence when you're met at the door in a prison. We forgive you, and we're here to help you heal. He totally has diminished the violence. He has the women growing organic vegetables in the garden because he wants them to be successful, to plant a seed and then grow the vegetables that serves the community. He has the young, tough women coming in serving their elder before they have their meal, that dignity, respect. These are all things that just happened as a result of people getting there's meaning behind behavior, right? Rather than us just treating that symptom, we're going back and healing the cause. If anyone saw Oprah, she did a 60 Minutes segment, but the best thing she did was preparing for that, she had an interview with her best friend, Gail King. And she said, I never knew anything about trauma. And she said, this has changed my worldview. We're doing everything wrong. She said, our housing programs are everything wrong. She went and she trained all of the staff. They trained all the staff at her school. But I love that she said, I get it now. What we have to do is heal the hole in our soul, right? And how many people do we serve that have big holes in their soul? So it's about lifting people up. They've already been taken down enough. Lifting people up and elevating them. And when people understand it, Bon Secours Hospital, Baltimore City, we've worked with a really challenged hospital that serves a really impoverished community. They're doing just incredible stuff. They have trained the housekeepers to be trauma-informed housekeepers. Because, what time is it? I just want to make sure I'm not.
You're okay.
Okay. Trauma-informed housekeepers, because what we heard was when the physicians go in for rounds and you're surrounding somebody's bed and there's a bunch of people in white coats and talk about power differential in this community and who oftentimes the staff were, no one talks. And the housekeeper said, when I come in, everybody unloads on me everything that's going on. So they train them to be part of that whole process. They're the trauma-informed housekeepers. It elevated them because they don't see themselves as, they're not invisible to people anymore. They're not just in there to clean up. They are in there to be part of this whole therapeutic milieu. Trauma-informed housekeepers, they were elevated. The patients were elevated. The people who worked with them saw them differently. These are the creative things, I think, that happen when we first go in and we can help all the staff understand how trauma affects us and then can help them understand that healing is possible. This is another really good one, DC Department of Corrections. They brought us in, they were doing a step-down unit from the the inpatient psych unit to a step-down unit before people went into general population. And so they said, well, what can we do? And I said, well, do you know who the inmates are that are going to be going on to that unit? Yep, we know. They're on the inpatient unit, they're going to be going to step-down. Do you know who the staff will be, who the officers will be? Yep, we know who them. I said, that's your committee. And they said, are you kidding me? Do you really want us to do a committee with inmates and officers? I'm like, yeah, I do. Let's see what happens. Well, they did it. It worked out beautifully. They made plans together. They picked the paint colors together. They picked motivational quotes to put on the walls together. The favorite thing they did, and the officers came up with this, every night from 8 to 10, where people were dysregulated, people were anxious, they play Al Green. Are you guys young enough to know who Al Green is, right? Does everybody know who Al Green is?
Yeah.
Right? Yeah. But
you said you wanted me to sing, Joan.
I did. Can you sing it? But who is going to fight to Al Green? No one. Right? No one's going to fight. But these are just really creative, fun things that really change the environment. And that's what implementing trauma-informed approaches or good practices is really, really about. It's looking at how that environment impacts us, and doing these environmental changes only enhances the good work that the clinicians can do. Because all that good work a clinician do can be undone the minute somebody goes onto a unit that they don't get it, right? So with that, one of the things that we realized when we understood that Dr. McCann's CATS was very much into us addressing serious mental illness, which we do, we decided we really need to do a project where we looked at the relationship between serious mental illness and trauma. So we were approved by SAMHSA to be able to do a several-part series. The first part will be, this should be available at the end of this year, so by end of September. The first part is a literature review, looking at what the literature show in terms of that relationship between unaddressed trauma and serious mental illness. So that's the first part. The second part is a review of best or emerging best practices in implementing trauma-informed approaches, and both on the clinical side and in the environmental side. The third is a survey of states. Thank you all who answered our poll on what's happening in your state in terms of implementing a trauma-informed approach. Because what we had the hunch was that in public health, it's really hard to get trauma-specific services. People that oftentimes go to trauma-specific services are in the private sector, right? Or you pay extra to see a psychotherapist who's trained in trauma, or an analyst, or whatever it might be. But in the public health arena, for all sorts of reasons, you're really not getting that trauma-specific services, so in most places. So we really wanted to look at a survey of the states, what's happening. And then finally, what Mark is going to talk about as well is we are doing a report from the medical directors on what the recommendations would be for states to move the trauma responsive services forward. And so that should be ready also by the end of the fiscal year. So with that, I think I'm going to hand it over to Mark, but I want to say quickly something that we'll be sending you out a notice for, but on August 23rd, we're going to have a virtual conference. This is an experiment. Rather than, a webinar that we do, but we were going to do a series once a month, we decided, why don't we do an all-day virtual conference that'll be archived on the opiate crisis, but taking it from a little different perspective on what would make a difference. So this is August 23rd. It'll be all day. Stuart will put it out in our newsletter once we get SAMHSA to approve our notice. I'm not going to say anything else about how long that takes, but let me just say you'll probably get it on the 22nd. But so I want you to know that on the 23rd, and what the first one is on grief. How does grief impact? How does the opiate epidemic affect parents, families, communities? So the first one is on grief, and it's a woman, a clinician who lost her son to fentanyl, and she's going to talk about her healing and what she's doing to give back to the community in his honor. The second one is will be a young woman who has struggled for years with addiction on what made a difference in her own healing and recovery. So her story is really compelling on how many times she overdosed and almost died, and her story on her recovery. The next one is going to be on the police interventions, and we're working with a great group of police in Baltimore City. They're called the Homeless Outreach Team, and 2 women, former homicide detectives, who are incredible in going out and doing outreach and services to people who are on the street and suffering. The next one will be on the courts. What are the courts' roles in addressing the opiate addiction? Then finally, we'll be working with our wonderful friends in Ohio, Ohio State, where they have actually really helped us realize the issue that community hospitals are experiencing with the opiate addiction, not just in ERs, but on med-surg units. Folks that are coming into the hospital on med-surg units, where you have nurses that are not prepared to address behavioral health issues, where you have people afraid to do prescription, where there isn't a lot of medically assisted treatment, but Mark's fixing that, right?
No problem.
So, but you are, and the issues around nurses being injured. There's a 30% increase in nurse injuries. So all sorts of different aspects of looking at the effects of the opiate epidemic in different areas where we oftentimes don't look at. So that's August 23rd. We'll send out notices. It's going to be archived, so you'll be able to see it. Look at it whenever you have time. So with that, I'm going to turn it over to Mark, who's going to talk about, I think, his journey, what Ohio's done just incredible work in moving the trauma responsive services across systems, and then he's going to share with you the medical director's recommendations.
Thank you.
Oh, you're going to walk?
You have the remote,
Oh,
please.
you're going to walk.
Well, no, I'm not going to. I'll sit here. I need you beside me.
Okay. I'm here for you.
And Joan is obviously very knowledgeable and a terrific trainer with this, and also just an incredible individual.
Thank you.
We met about 15 years ago when I was medical director of a state hospital in Columbus, and Joan came to train the hospital in trauma-informed care. And it's quite an experience because Joan and her team train 3 shifts and do it over the course of several days. So I don't know when you sleep during that
I don't
time.
know why we do that.
But all that really needs to be trained is day shift.
Well,
right?
because we always say you need to
it's not
train
like
the
the
night
whole
shift, and then it falls back.
It's not
on
like the
us.
whole hospital needs to be or anything. But
Right. Right.
I was pretty stressed at that particular point, and Joan obviously sensed that and said, "How are you doing?" And it really just kind of broke the ice and made my day so much better. And so just that clinical skill and ability to detect that is really appreciated. I was supposed to speak here last year, and 2 days before I came, I broke my shoulder and was unable to travel. So I've spent the last week wondering, I'm not going to fall again and break my shoulder, am I? So I'm really happy to be here, and was in the new director's training 2 days ago. And I think I must have learned something in there, because when I sat down here and Sheri started to talk, my phone went off. And I recognized that it's the governor's senior aide.
Uh-oh.
So I think I'm getting like my indoctrination into being a commissioner, Wayne. So thanks for helping me prepare for that. So here's a little bit of the journey that we've gone through in Ohio with this. And so I think it's obvious to all of us that this is the right thing to do. So many of our people have been traumatized. It has such impact on their life. Of course, it's the right thing to do. But like many things, just because something is the right thing to do doesn't necessarily mean we can actually do it and implement it. So we really needed to start with this in terms of how do we sell this? And how do we sell it to our leadership of the state? And how do we sell this around the state so we can have agencies, we can have individual practitioners who are really interested in doing this and helping us move it forward. So of course, one way to do that is just to look at the prevalence of it, and I'm not going to read each of these slides one by one or anything like that, but it's very prevalent. And we also Ohioized the data. Because we have national data and it's like, well, okay, great, but what's going on in our state? And not surprisingly, what goes on in Ohio parallels what goes on elsewhere in the country. That those who have a mental illness have a very high rate of physical abuse, sexual abuse, or have witnessed domestic violence. Those who have had a substance use disorder have slightly less, but still a very high rate. And if you look at them about individuals who have had just one of those, it's over half of the people who have mental illness and addiction who have experienced various kinds of trauma. And then, of course, if you look at people who have both an addictive disorder and mental illness, the rates are very high also. So as we got started in this, one of the messages that we got from upper level administration was stay in your lane. Work with people who have mental illness and addictive disorders. And, this kind of gulled me a little bit because I, knew very much that this was equally applicable to the general health care system and things like that. And in fact, could perhaps even be more relevant to that in terms of outcomes and things like that. But, we got the message, stay in your lane. And I said, yeah, sure. We'll see how this evolves. And it did evolve over time. So we'll talk a little bit about that. And we needed to educate people about the ACEs. And I think everybody knows the ACEs categories, 3 different kinds of abuse and neglect, and then other life experiences like witnessing domestic violence, substance abuse in the household, mental illness in the household, parental separation or divorce, or incarceration of a family member. Of course, there are many other traumatic events that people experience which also have adverse effects, but these are the ones that were looked at in the ACEs study, and I think all of us are familiar with that. And Joan touched on the opioid epidemic, which should worry us a lot in terms of our kids. That when we see kids who have been exposed in utero to opioids, so they have an addicted mother for sure, that frequently they have been separated from that parent not long after birth or at some point, by incarceration sometimes, by death sometimes, just by the parent being absent due to addiction. It doesn't take long to see how a child could have 3 or 4 ACEs within the first year of their life. And that's something that should really concern us and something that we really need to focus on as part of our opioid initiative here. And the reason we need to do that is because the more ACEs you have, the less likely that life is going to turn out well for you. And certainly it's true for mental health. If I said, well, if you have multiple childhood traumatic events, you're more likely to be depressed, you're more likely to use substances, everybody would believe that. But if I said, well, additionally, you're more likely to have cancer, you're more likely to have COPD, you're more likely to have preterm births, you're more likely to have STDs, you're more likely to have heart disease, you're more likely to have cancer, you're more likely to die a premature death. People have trouble believing that. But that is why this is such a public health issue. It is not only a public behavioral health issue, it is a total public health issue. And there are things that aren't even on here. Like individuals who have had multiple trauma are less likely to graduate from high school. They're less likely to have economic success in life. They're more likely to have divorces. Life just doesn't turn out well. So the prevention and addressing of trauma is something that's really critical. I don't need to sell this to all of you, but I did need to sell it to a lot of people in Ohio, and had a great team that was willing to do it. So it really got down to saying why this is so important. Trauma is widespread. It contributes to many illnesses and healthcare costs. Most people with mental illness and substance use disorder have experienced trauma. In foster care systems, virtually everyone has experienced trauma. It's highly associated with medical illness, and it can impact the physical health, the emotional health, and again, I would argue the economic health of a society if we can do this correctly. But we need to do it comprehensively. And as we were doing this, there was a tragic event that occurred in Connecticut at Sandy Hook, just as we were starting to build this up. So Tracy Plowk, and who many of you know, and I were called over to the governor's office, and the governor was very concerned and said, what can we do about this? And so we mentioned a few things, one of which was trauma-informed care, which was really kind of a small piece of it, but at least it kind of gave us the inroad to start talking about trauma-informed care, as well as a variety of other things. And the governor said, yeah, let's do that. So it was, it was really kind of taking this terrible experience, but being able to move our system forward in some way as a result of that. Now, we knew that we had expertise within Ohio already, that we had a lot of agencies and individual practitioners who knew about trauma-informed care, individuals who were experienced in treating trauma. So we had a core of people who were really believers already, and we needed to capitalize on that. But despite that, most of the system really was not prepared. So there was still very much a need for the staff and the facilities to be trained in this. And often those agencies and communities just didn't have the resources to do it. If you're an agency that's on the cusp of financial viability, bringing someone in to train on trauma, some of whom we well know can cost you $10,000 for a day, is just not something that's on the table. Not to mention the productivity that you lose by pulling your staff out to attend these trainings. So we wanted to provide support in ways that this could be a cost-effective intervention. And we needed to mention what it was, too, because there was a lot of confusion about this. There still is a lot of confusion. Well, what's this trauma-informed care? People have trauma, you need to give them therapy. Isn't that what it's all about? And I said, no, that's really not what it's all about. It's about the service delivery system. And it's important to change the milieu of that service delivery system, considering the trauma that individuals have experienced. And we needed to make sure that every part of the organization knows about it. Joan talked about the different parts of the organization that needed to know about. And you mentioned you always start with the intake point. Mm-hmm. So just a little bit of personal revealing here. I had my gallbladder out a few years ago. You'd think I'm like a really high utilizer of medical services or something. I'll break my arm, I have my gallbladder out, things like that. So, I go to the hospital for that morning. I'm a physician, so, I'm used to being around hospitals and all, but, it's my gallbladder this time, and I'm kind of nervous about the surgery and all. So I'm sitting there next to my wife, and I'm kind of fidgeting and things like that. And as I'm doing that, this peaceful, melodic voice comes out, and it says, "Hurst!" So I dutifully went over to the registration, and they informed me that my portion was anticipated to be $1,500, and if I could please pay that by credit card or cash right now, that would be very helpful.
There you go.
That ain't no way to go into surgery. And certainly isn't trauma-informed. Now, the rest of my experience, it's a very well-respected hospital, and, the rest of the experience was terrific. I couldn't have complained about the service I received after that. But it raised the point to me about how important it is for your whole organization to be trauma-informed. The person who answers your phone is the most important person in your facility.
Yeah.
And so, it really kind of emphasized that. And one of the advantages of being a physician is if you call a hospital CEO, they usually will take your call. So I did call a hospital CEO later, and I said, hey, you might want to take a look at, the training, and you might also want to take a look at asking people for money right before they go into surgery. And so I don't know if this had anything to do with it, but they changed their policy. So now they call like 3 or 4 days before you have your surgery and ask for it, which is better than asking right before surgery. So, the progress, not perfection. Yeah. So, that's kind of how that unfolded. The other thing was we wanted to make sure that we weren't endorsing any particular approach to trauma-informed care. There are lots of different approaches out there, and you can have an organization come in and train your facility and help you become trauma-informed care for $100,000. Literally.
Hey, I made a mistake.
You did make a mistake. You're cheap, And you were free for Ohio.
I know.
Because we did it under a service agreement here. But even in the absence of that, Joan and Raul and her team, if there's not grant funding available, it's very reasonable to have them come into a facility or a state to help out. So I would encourage that because they helped us a lot in Ohio. But again, we wanted to make sure that we weren't endorsing anything because you can do this inexpensively. So our goals were make it available, make it inexpensive, and make it work. So that was where we started. So as I talked to Tracy about this initially, she said, well, many of you may not know, Tracy started her career as a budget analyst, and she's never let that go. And so she said, well, what's it going to cost? And I said, I don't want a budget for this. And he said, well, tell me a little bit about that. I said, well, I think we've all seen times where we do grants and we do things like that, and some people who are interested in the particular project take the funding and do a good job of moving it forward. And others who are interested in the funding take the funding, and then when the funding isn't continued, that project goes away. And I don't think that's any way for us to build a state system with this. And she said, I'm in. So we really wanted it to be more based on the passion of those who were involved in the initiative, and there were a lot of passionate people who were involved, especially line staff. Bringing the administrative staff along at the different organizations was a little bit more difficult task, and we had an approach to do that. So we didn't have a lot of infusion of resources. We really encouraged repurposing of the resources that folks had already. We used NCTIC as a consultant and to provide a lot of training in Ohio, and especially in the end to train our own Ohio trainers so we could sustain it within the state of Ohio. And then we encouraged the different parts of the state to develop their own expertise of it. So, again, lots of different models to do this, but they all really stick to what the basic principles are that you can find many places, including in SAMHSA publications. Safety, trustworthiness and transparency, collaboration, mutuality, empowerment, voice and choice, peer support, mutual self-help, and then cultural, historical, and gender issues. If you hit all of those, you're going to be well on your road to becoming trauma-informed, and of course building on strength. So of course we have to have a vision and a mission statement and things like that, but basically it was that we wanted the state to become progressively more trauma-informed. So we had a framework to do that, and we started out by building an interdepartmental team who would actually do the work of this to make sure that we did it. And because we have kind of some direct influence, we felt that we should start within our own system and develop TIC within our department and within our state hospital system. So we started this out by having Raul Almazar come in along with a person with lived experience, and they did a terrific training for all the leadership of our hospitals as well as the whole leadership of our department. And this was the same year where the Department of Drug and Alcohol Addiction Services and Mental Health merged. And this was really the first event that we had that had the leadership of the combined departments with it. So it really launched the new department in a trauma-informed way also. Had a little bit of funding from it, from the funding that came from the Sandy Hook conversations, but really we didn't have a whole lot about that. And of course we were working with our partners in the community with that. And then we had to come up with a statewide propagation plan. We did start implementing it within our departments and did that kind of collaboration. But at the same time, we realized that that's really not enough. If individuals with severe mental illness have a trauma-informed environment within the state hospital system, and then they leave and they go to public mental health centers that don't have that, how are we going to be doing in the future? We need that kind of continuity. The next step that we're still working on is recognizing that it is a cruel world for people who have severe mental illness, and that they are subject to violence and they are subject to other things in the community. And how can we spread this even further to communities, to correctional facilities, to other places that interface with our patients and our clients? And we're still working on everything. I think we joke sometimes, one way you know an organization is not trauma-informed is if they say, we're trauma-informed and we've got it all figured out, because you never have it all figured out. There's always more work to do with it. So again, we started with our state hospital in 2013 with that, with a lot of assistance from Joan and her team. We were able to get an FTE, a project coordinator for this, Kim Kale, who's just a terrific fellow and has been really helpful. And we had an advisory group of folks from the outside, including and especially people with lived experience. And of course, we all know that that's something that's really critical to do that. And we developed a website too. So then how are we going to propagate this around the state? How are we going to get different regions and outpatient areas doing that? So we thought, well, we'll have a summit to start with this. And so we had our first annual Trauma-Informed Care Summit in 2014. We just did our 5th one last year, and they've all taken a little bit different form. And that first year, I got Raul Almazar and a person with lived experience presented. The second year, Joan presented. The third year, Brian Sims presented. And then we ran out of people. So we had to ask people from elsewhere than the TIC. So it was really the kind of the fundamentals of all of this. And we specifically wanted to target the leaders of the state health, human services departments, as well as administrative and clinical leaders in the area. So a lot of people wanted to come who were clinicians, and we said, we're going to keep working on that, but we need to get your leadership involved with this so we can take a top-down, bottom-up approach for it really to be effective. The second part of that was to develop regional collaboratives and to have groups of people who had a passion for this to develop it in the regions of the state. So how do you sell this to bureaucrats? It's the right thing to do, but how's it going to affect my bottom line? So even if you are the most cold-hearted bureaucrat, you need to know that trauma-informed care is going to have an impact on your organization in a positive way. Improve quality and impact of care. So as we move to value-based reimbursement and things like that, you want to have better outcomes. So that's something that's helpful. Improved safety for patients and staff. That you will have decreased injuries in your staff as you implement trauma-informed care. You'll have less seclusion and restraint. You won't have as many no-shows, which is a problem for a lot of agencies. Patients will be better engaged, they'll be more satisfied, staff will be more satisfied, and you'll have less staff turnover too. All of these things are really important to agency directors. So as we were beginning to implement this and saying you can do this on the cheap really, that same month Tip 57 came out about trauma-informed care and behavioral health care services. So a free resource. And so we were able to really use this as the basis of trauma-informed care in Ohio. So people could go to that instead of hiring consultants to come in. We divided the state up into 6 regions, which were based on our hospital catchment areas, not because they're the end of the world, but because we had to divide it somehow, and the hospitals have free meeting space. So it was purely pragmatic that we decided to do that, and that worked out very well. Initially, we had our staff help facilitate those. Over the past several years, the areas have taken that up on their own. So that's been something that has been really nice to see. They've done some great work. They've developed their own website in places. They have done YouTube videos about people who have experienced trauma, with them speaking directly. And child welfare has also become increasingly involved. So that's been really helpful. So how's it gone since we opened? Since we opened, how's it gone since then? It's gone very well. We've developed curricula. Some hospitals have unique curricula, but it's to build positive and collaborative relationships. We have newsletters on a regular basis, recovery cafes, and what I really want to talk about is a value-based hiring process using trauma-informed care processes. And so Appalachian behavioral health is in one of our most economically deprived areas of the state. And so they had been having difficulties with retaining new hires, which is really something in an economically deprived area of the state. People need the jobs, yet they were leaving those jobs. So they said, well, let's do something a little bit differently. Let's interview differently and make sure we're hiring the right people. And let's look at these kind of characteristics of the person before we hire them. Compassion, collaboration, innovation, integrity, so on and so forth. So what happened with that? And the year before this was implemented, there was about a 26% retention rate of new hires. And the year following that, there was a 69% retention rate. It was better matching the individual's personal characteristics to what the job is. And so that is something that had been very impactful in that organization. As of a couple of months ago, there have been about 14,000 people in Ohio trained in trauma-informed approaches. That was all done through a train-the-trainer approach, which was based upon Tip 57. And so we have just a little bit less than 200 trainers in Ohio. When we trained them, we said, we will train you for free, and we expect you to do your trainings for free, and they have held to that very well. And so we have really been able to have many individuals and facilities who have experienced that. And then it's gone beyond that. So this is the getting out of our lane part of it. And we didn't drive out of our lane, but people asked us to come out of our lane and meet them. As we started this, we said, we want to do this not by promotion, but by attraction. And as more people heard about trauma-informed care, more people wanted to know about it, and more people wanted training with it. So we've worked with early childhood with that. We've worked with the Attorney General's victims of crime with this. We worked with the Department of Aging to roll out a trauma-informed approach in terms of responding to older adults, which has been very successful and very interesting. A family physician colleague of mine said that he was talking to a woman in her 90s, and she was having certain symptoms, and he said, you know, I'm just wondering if you were ever abused as a child. She said, I'm 92 years old, and nobody's ever asked me that before. And yes, I have been. And so this is a lifelong issue. The effects of childhood have lifelong effects, but people can be traumatized at any time in their life too. Ohio Veterans Homes is another organization that reached out to us and we've had involvement with. Found out some very interesting things. Many of the people, of course, in the Veterans Home have experienced trauma, and some have post-traumatic stress disorder. And next to the Veterans Home is a veteran cemetery. And when they bury a veteran, what do you think they do? A 21-gun salute. And so people are diving and, you know, re-experiencing traumatic experiences and all of that. So we were help them able to coordinate with the cemetery to be able to know when that's happening and have it be less traumatic to them. Trauma-informed policing. The Ohio Peace Officer Training Academy wanted to have training on trauma-informed care. And it started so they would know how better to act to individuals who had experienced trauma in the community. And it evolved to us working quite a bit with the police, the firefighters, and other about the secondary trauma that they experience. So that was really kind of another fruit that came out of that. So it's probably equal emphasis with those. We've worked with churches on this, and then we have also worked with the opioid response, as I mentioned earlier. So a question, and we have to have audience participation here. Is having a trauma-informed healthcare system enough? Yes or no? How many say yes? How many say no? How many aren't going to commit? Okay, yeah, and I think we would agree, probably not. And especially as we look at individuals with serious mental illness. And this gets us to talking about some of the recommendations that we have based upon the survey that was done and the technical assistance paper and things like that. So our first recommendation is that all treatment providers should become trauma-informed and fully implement the practices throughout their organizations. I think that only makes sense. All people with severe mental illness should be screened for traumatic experiences that might have occurred throughout their life from childhood to the present. Because what we know is not only have they frequently experienced traumatic experiences, but we know that the more traumatic experiences they have had, the more severe their symptoms are and the less responsive to treatment they are. So addressing this is a very important component of what we need to do. All treatment with severe mental illness should consider trauma histories and its effect on their course, their treatment adherence, and their response. So, imagine somebody, is that like telling me to stop, Sheri?
Pretty soon.
Pretty soon, okay.
How much more time does he have?
There's 10 minutes in our
Because the trauma is going to explain how they react to treatment. If a person experienced sexual abuse at the hands of a male relative, maybe a male case manager is not the best person for that person to have. If a person was tortured in their life with sharp objects, maybe needles aren't a good thing for that person. Just need to look at all of those things, especially when there are unexpected reactions to what we think are routine things. All people with SMI and history of trauma should get trauma interventions that are evidence-based and specific to SMI as part of their comprehensive treatment plan. There are lots of interventions for trauma that are out there, some of which are not evidence-based for anybody, and most of which are not evidence-based for people with severe mental illness. So we need to be sure that those interventions that we're using are appropriate for the condition that someone may have. Organizations and practices treating people with SMI should establish specific approaches to decrease the likelihood of victimization. Because we know that although in the press we read so frequently about people with severe mental illness perpetuating violence, we know how much greater the risk of them being afflicted with violence is. So we need to be aware of that and their re-traumatization and be able to try to avoid it and address it as early as we can. All treatment providers should make serious efforts to decrease seclusion, restraint, and coercive interventions that contribute to re-traumatization within their organizations and practices with a goal of total elimination. And that's another one of those things, as Brian was talking about. Is 0 a reasonable goal?
Yes.
Well, what goal is reasonable other than 0? People should implement staff self-care programs and approaches to improve wellness, retention, and patient outcomes. It's hard for injured staff to treat injured patients. And I think one of the deficiencies that we had, and we're trying to deal with that now, is that we didn't consider this enough as we were rolling this program out. On some level, I almost wish we would have started with staff rather than starting with the patients. But you need to do it simultaneously at least. We should have processes in place to respond to staff members who experience primary or vicarious trauma. And they should be implemented in all areas of the treatment continuum, and I would say even the community accessed by individuals with SMI. So those are the recommendations we came out with, and they're still in a draft form, so we're certainly willing to hear more about that. So why is this important? Traumatic events occur throughout our country every day, and we just need to look at today and the wildfires out in California. But certainly 9/11 affected people well beyond those who were at the Pentagon or who were in New York City or in the fields of Pennsylvania that day. The rest of these are from Ohio. This is flooding that occurs almost every year in Findlay, Ohio. There was a shooting at Case Western Reserve University, tornadoes, and then there was a shooting at Chardon High School about 6 years ago also. And these are the events that we see. More damaging, or at least equally damaging, are the events that we don't see. Those that occur behind closed doors and are perpetuated by individuals who are the people who should love and care for the individual who experiences the trauma. That violation of trust is just such a dramatic and traumatic thing that occurs. So of course it's important, and we have ways to do it. We're living in a society where compassion and kindness seem to be at a premium. And we can't lose the compassion that people have, particularly the individuals we treat who have had serious mental illness and have serious mental illness. The world's not a friendly place for them, and they've faced so little kindness in their life. We really need to be able to promote that kindness in evidence-based ways so we can help them recover and help them live in society. So we have a web page, and we'd like you to take a look at that if you would like, and certainly feel free to give me a call or any of us. And I think that's about what I have to say.
Great. I think we have just a couple minutes for questions to stay on time.
Not so much a question. In my private practice days, I specialized in treating adults with early complex trauma histories. And as a result of that experience, I would recommend that you consider another recommendation, and it's got to do with being able to do differential diagnosis between dissociative disorders and psychosis. And that so many times those with a complex trauma history get misdiagnosed, put on psychotropic medications, etc., that just further complicate their clinical profile and can result in re-traumatization as well.
That's a great point, Wayne. I think we hit the treatment part, but we didn't hit the assessment part, and that will be a nice addition. Thank you.
But it certainly did come out in the literature review that we did, so that will be, you have a lot of references for it in the lit review.
All right.
Here comes Deb.
I got a question.
Okay.
Sorry, everyone wants to go, but I know we talked about this in our medical director's discussions, but one of the things that I'm struggling with in state hospitals, which are traumatizing environments, yet they're tertiary care centers where we are working with people who are intensively, who have those trauma histories, as you described so well and eloquently. But we don't really do trauma-specific work in the hospitals. Mm-hmm. And there's a lot of discussion about whether the hospital is the right place or the wrong place to do it. We don't do it on acute psychiatric units typically either. It sort of may get acknowledged if it's a good trauma-informed unit, but it's not going to get dealt with. And so I guess just in thinking about the presentation in light of the recommendations, I wonder what we need to say about where trauma-specific therapies should or shouldn't happen, and what needs to be in place to ensure a safe environment for that work to happen.
Yeah, that's a great question. I think the wrong answer is not here, which we have so much in our field. This person has condition X. Where can they get treatment? Well, I don't know, not here. And so I think there's a part of being welcoming, and in terms of recognizing we're not going to resolve all the issues with trauma, but we can at least get started with it. I mean, because somebody comes into our hospital with a major depressive disorder and they're not going to be able to get 20 sessions of cognitive behavioral therapy for that, does that mean we don't do cognitive behavioral therapy for depression in the hospital? No. We still do it, but we do a handoff to an appropriate provider. So I guess that's kind of where I am with that, Deb, if that makes sense.
Yeah, and I'd like to add that in many of the programs that we're in, whether it's a hospital or substance use or criminal justice, we do more of a psychoeducational, manualized process rather than a dynamic kind of clinical process. There are lots of different manualized psychoeducational where you can give people ways to, if you're becoming dissociative, to ground yourself, or what you can do if you start to feel that anxiety. that don't rely on you telling your own personal story of trauma. It's much more informative on helping people connect the dots.
I have one more thing I'd kind of like to mention, and that's why this is important to me personally. When I was growing up in Appalachia, I had this little friend that I used to play with whose name was Jennifer. And I just loved her, and she was smart and fun and all kinds of things like that. And then when her family was about when she was about 7 or 8, her parents separated, and she moved into the same neighborhood I lived in, which I thought was just terrific. And so we got to play together a lot. And then one day I was playing with her, and there was a knock on the door, and it was her father. And he was intoxicated, and it was really ugly. I got out of there. I don't have any idea what happened, but I got out of there. I don't know if somebody ushered me out or whatever. What I do know is that's the last day I ever played with Jennifer. And it's a small town, so you know what goes on and things like that. And I knew that by the time she was in her early teens, she was sexually active and drinking. And by the time she was in her mid-teens, she was promiscuous and was using drugs. She was truant from school. I don't know if she ever graduated, and there was no reason in terms of her intellect that she shouldn't, because she was really smart. And then I lost track of her. Until one day, about 10 years or so ago, when I woke up in the middle of the night thinking about Jennifer, who I hadn't thought of for 40 years, and concerned about her well-being. And so, next day I was kind of, a little bit, what's that all about? And my wife's a psychiatrist too, which, has its good points and its less good points. Deb knows what I mean. And she said, what's up? Somebody told her, and she goes, well, you should probably talk to your mom about it. She knows everybody in that town. I said, okay. So next time I was talking to my mom, I said, you remember Jennifer? She goes, yeah, I remember Jennifer. So I said, well, whatever happened to her? And she said, well, why do you want to know? I knew it wasn't going to be a good story. So I told her, and she goes, well, okay. She ended up marrying this guy who was physically abusive to her. She had multiple encounters in substance abuse rehab. She was hospitalized psychiatrically. A few years back, she contracted cancer, and she died. So point one was that this is what happens to people who have had multiple life traumas like this. Substance abuse, mental illness, incarceration, continued intergenerational abuse and things like that, cancer, early death. But that's not the end of it, because after we continued to talk and went through our usual conversation, how's work, how are the kids, haven't seen you for 3 weeks, 2 days, 14 hours, those kind of things. My mom said to me, I think Jennifer's probably doing just fine. And that brought everything together for me. It was a tremendously profound comment, because here I have a mother who's 93, who's still telling things to me that help me feel like the world is okay. And Jennifer didn't have that. And I look at where my life is, which couldn't be much better. I complain, and there is no way I should complain. And her life couldn't have been much worse. And I don't think it has to do with what we brought into this world. I think it has to do with what we experienced in this world. And so that's a real personal reason that I think this is important. And all of us know Jennifer's. Jennifer is in every psychiatric clinic, every emergency department, every prison, every neighborhood in our country. And we can do a better job for the Jennifers of this world. And I can't help but wonder, if we would have intervened with Jennifer when she was 7 or 8, or 12 or 13, would her life trajectory have been different? And I think it would have been. And so there are good scientific reasons we need to do this. And there are good societal reasons, and there are good interpersonal reasons that we need to. And I appreciate everybody all over the country who's working on this. And I want you to help me, and I want to be able to help you too.